Hello everyone. Today we are going to discuss about the peritoneum. Peritoneum is a large serous membrane lining the abdominal cavity as well as the viscera within the abdominal cavity. This is the largest serous membrane. It not only supports the viscera but also provides pathways for blood vessels, nerves and lymphatics to travel to and from the viscera. To develop it, it is a closed sac which is invaginated by the developing viscera from one side in such a way that ultimately it becomes a two-layered structure which is being invaginated by the viscera. Because of the invagination of viscera, the peritoneum is divided into two layers. The outer one, which is lining the wall of the abdominal cavity, is called as parietal peritoneum, and the one which is lining the viscera is called as visceral peritoneum. In between the two, there is a potential space which is called as peritoneal cavity. The parietal peritoneum, which is lining the wall of the abdominal cavity, it is not only lining the abdominal cavity but also the pelvic cavity. It is derived from somatopleuric layer of the lateral plate mesoderm, and its blood supply is from the overlying wall, and because it is supplied by the somatic nerves, that is why it is sensitive to pain and temperature. The visceral peritoneum, it surrounds the viscera within the abdominopelvic cavity, and it is closely applied to the viscera and adherent to the viscera. It is derived from the splanchno-pleuric layer of lateral plate mesoderm, which lies close to the yolk sac. Because of its close contact with the viscera, its nerve supply is also derived from the underlying viscera, which is autonomic in nature, and because of that, this part of the peritoneum, that is visceral peritoneum, is sensitive to pain only due to stretching of the viscera, distension of the viscera, or anything causing ischemia of the viscera. The space between the two layers is called as peritoneal cavity, and it contains a minimal amount of fluid called peritoneal fluid, which helps in lubricating the two adjacent surfaces of the peritoneum for friction-free movement during various movements of the viscera because of the food inside it or because of the respiration. This peritoneal sac is closed in case of males, but it is open in case of females because of the uterine tubes opening into the peritoneal sac, and through the uterine tube it is open to the exterior by the uterine cavity and the vaginal cavity. Abdominal viscera, depending upon its relation with the peritoneum, is divided into mainly two groups, the intraperitoneal and retroperitoneal organs. The intraperitoneal organs are enveloped all around by the peritoneum, like this. And for example, this is typically found in most of the GIT organs like stomach, ileum, jejunum, then transverse colon, liver and spleen. Retroperitoneal organs are those which lie behind the peritoneum and only covered on the anterior surface by the peritoneum, like we can see in these two pictures. Such organs are divided into two groups. The primary retroperitoneal organs are basically those organs which have developed from that area which lies behind the peritoneal layer or the coelomic membrane. And such organs generally develop from intermediate mesoderm, with few exceptions, and such organs like kidney, suprarenal gland and testes are developing behind the peritoneum, so they are primarily retroperitoneal. Along with that, there are certain other organs like esophagus and rectum also develop behind the peritoneum, so they are also primarily retroperitoneal organs. Then another group is of secondary retroperitoneal organs. These organs generally develop in the beginning as intraperitoneal organs or the viscera. Later on, with further development within the abdominal cavity, the mesentery of these organs, it falls onto the posterior wall of the abdominal cavity, and the adjacent peritoneal layers, they fuse and get absorbed in such a way that that particular viscera surrounded by the peritoneal layer only on the anterior and the lateral aspect, and posteriorly there is no peritoneum found. So such organs are called as secondary retroperitoneal organs, and typical examples of such organs is second and the third part of the duodenum, then pancreas except tail of the pancreas, then ascending and the descending colon and upper part of the rectum. And the process of fusion and absorption of two peritoneal layers is called as zygosis, and
this is the anterior abdominal wall and the diaphragm here, thoraco-abdominal diaphragm. Now the posterior abdominal wall, lumbar region, and the sacral region. Now let's put some of the viscera in here. First of all, I will put the liver, diaphragmatic and visceral. This is the visceral surface of the liver, returning back to the diaphragmatic surface of the liver. And then here's the stomach, the wall of the stomach. I will put some rugae here to indicate that it's a stomach. Then the colon, this is the transverse colon actually, and on the posterior abdominal wall I'll draw the pancreas, and then I'll draw the small intestine, a loop of small intestine here. Then let's put some of the pelvic viscera. Here we have the rectum and anal canal, and this is a female subject, so I'll draw the uterus and vagina. This is a posterior vaginal fornix here, and anteriorly is the urethra and the urinary bladder in front of the pubic symphysis. Now let's sketch the peritoneum. I'll draw the parietal peritoneum in blue. So I will start in the region at the anterior abdominal wall. that is probably close to the umbilicus, go up. This is parietal peritoneum of the anterior abdominal wall, and then the peritoneum lines the diaphragm and reflected from the diaphragm to the diaphragmatic surface of the liver. Here, as it is reflected on the liver, it will form the visceral peritoneum. So I will change the color into pink, and this is the visceral peritoneum now, covering the liver, the diaphragmatic surface of the liver, and then it is reflected on the visceral surface of the liver here, close to the hilum of the liver. It will be reflected as the anterior layer of the lesser omentum between the liver and the lesser curvature of the stomach. This is the stomach, and then passing on the anterior surface of the stomach to the greater curvature of the stomach, and then reflected from the greater curvature of the stomach as the greater omentum. So this is the anterior layer of the greater omentum. The greater omentum is a double layer, and it will be reflected backwards toward the transverse colon. So it passes around the transverse colon, peritoneum, the visceral peritoneum, and then reflected from the transverse colon to the posterior abdominal wall, where it reaches the site of the pancreas. This reflection is called the transverse mesocolon. Then it covers the pancreas. Most of the pancreas is a retroperitoneal structure. It has no mesentery, unlike the, for example, here we have the transverse colon, which has mesentery. This is a piece of peritoneum that extends from the transverse colon to the posterior abdominal wall. And then as this peritoneum covers the pancreas, it is still visceral peritoneum, but as it reaches the posterior abdominal wall, now it becomes the parietal peritoneum. So I'm going to continue it in blue, covering the posterior abdominal wall, and then reflected from the posterior abdominal wall at the left of the transverse process of L2 vertebra. It will be reflected as the mesentery of the small intestine. Now it should be visceral peritoneum. So this is a visceral peritoneum as a double fold of visceral peritoneum. It encloses the small intestine, and this is a loop of small intestine representing that, and returns back as a double fold of peritoneum to the posterior abdominal wall. So this is the mesentery of the small intestine. Now at this point it will come back to be a parietal peritoneum, and so I'm going to draw it in blue, and continues as the parietal peritoneum of the posterior abdominal wall, then onto the pelvis, and as it reaches the rectum, it will be reflected in the front of the rectum. The rectum has no mesentery, and peritoneum will be reflected as a visceral peritoneum in the front of the rectum, then dips into a pouch that is reflected from the rectum onto the posterior vaginal fornix, and then onto the posterior wall of the uterus. This is the rectouterine pouch, or the pouch of Douglas. In the male, it is reflected directly onto the urinary bladder and is called the rectovesical pouch, but in the female, it is reflected onto the posterior vaginal fornix and the posterior wall of the uterus. It covers the entire posterior wall of the uterus, reflected onto the fundus, and then the anterior wall of the uterus, about upper 2/3, and reflected on the urinary bladder, upper surface of the urinary bladder, creating another pouch here, and that is the uterovesical pouch. This pouch is not present in the male, because in the male there is no vagina and uterus intervening between the rectum and the urinary bladder. And here the peritoneum will be reflected back to the anterior abdominal wall, becoming parietal peritoneum. I'm going to change the color into blue. So this is the parietal peritoneum reflected onto the anterior abdominal wall and returning back as the parietal peritoneum of the anterior abdominal wall into the point where we first started. We've started here approximately at the level of the umbilicus. So you can see here that the peritoneum is a continuous layer. It's a continuous sheet and where it lines the walls, it is called parietal. Where it covers the viscera, it is called the visceral. The peritoneal cavity is a continuous cavity from the abdomen into the pelvis, and this cavity is located between the visceral and parietal layers of peritoneum. It is exaggerated here in this diagram, otherwise it is a potential space, and the two layers are, in many places, they are opposed to each other, and where there is a double layer of peritoneum, as we see here in the small intestine, it is called mesentery, sometimes it's called ligament, sometimes it's called omentum, like here in the lesser omentum and the greater omentum. Now let's continue this diagram, because here this sac, this part of the peritoneal cavity here, this is called the greater sac, and there is another sac which is located mainly behind the stomach, behind the liver, and extends a little bit into the greater omentum. This is called the lesser sac. So let me draw the lesser sac. This is again a visceral peritoneum covering the liver, and then the visceral surface of the liver will be reflected onto the lesser curvature of the stomach, creating a double fold with the fold that we have just drawn earlier, and then on the back of the stomach, returning into the greater curvature of the stomach, and this continues as a fold, double fold, with the fold that we have just drawn of the greater omentum, and returns back to enclose the transverse colon, and reflected backwards to the posterior abdominal wall as the transverse mesocolon until it reaches the pancreas, which is retroperitoneal structure. Now it will become a parietal peritoneum, so I change the color into blue, and that is the parietal peritoneum, returning back to the same point. This creates a sac, a lesser sac, or we call it the omental bursa, that is located behind the stomach. At the beginning, this, embryologically speaking, this sac was not present, but because of the folding of the gut, and because mainly of the rotation of the stomach, then this diverticulum or recess will be created behind the stomach, and this recess communicates with the greater sac through an opening. This is the approximate site of the opening. It is said to be located in the free border of the lesser omentum, and it is called the epiploic foramen, or the foramen of Winslow. It represents the only communication between the greater sac and the lesser sac. This arrow here goes from the greater sac into the lesser sac through the epiploic foramen, and this is the only natural communication between the two. Otherwise, in order to access the lesser sac, you have to either cut or incise the lesser omentum, or you can cut or incise this part of the greater omentum that extends between the greater curvature of the stomach and the transverse colon, that is called the gastrocolic omentum, or you can incise or cut this double fold of peritoneum here between the transverse colon and the pancreas, which is the transverse mesocolon. But keep in mind that all these peritoneal folds are vascular folds, and so they contain blood vessels. Also, I want you to notice the extension of the lesser sac into the greater omentum. In life, this extension of the lesser sac into the greater omentum is obliterated, so the gastrocolic omentum is fusing with the anterior surface of the colon, and these folds are brought together. Instead of having 4 layers, they will become double layers, and the lesser sac is confined to the area that is behind the stomach and behind the liver. Also, I want you to notice here that the liver is not completely covered by peritoneum, as you can see here, and that there is an area here in the liver that is the bare area of the liver, it is called, where the liver is in direct contact with the diaphragm, and this area is located between two folds of peritoneum that are called the coronary ligament. So this is the superior and inferior layers of the coronary ligament. Here I want you to notice that the peritoneum, again, the peritoneum of the abdomen is continuous with that of the pelvis, and you can see here the peritoneum is as if it is draped over pelvic viscera, which are located outside the peritoneum. This is an important relation here, the posterior vaginal fornix, which is related to the peritoneum. This is the only part of the vagina that is related to the peritoneum. The urinary bladder has its superior surface, only the superior surface of the urinary bladder in the female is related to the peritoneum. Now let me follow the peritoneum in a horizontal section, almost at the level of T12 vertebra. I will arrange the viscera so that the section looks similar to the axial CT or MRI section, because you will be more familiar with these sections better than displaying them in an anatomical section. In other words, I will draw the section so that as if you are looking at the section of the body from below. So this is the liver, visceral surface of the liver here. Now let me draw the stomach. This is a section on the stomach showing the part of the body, and this represents the rugae, the longitudinal folds of the mucosa of the stomach. Here the rugae lead into the pyloric canal. Also on the left side of the body, the other viscus is the spleen. So this is the spleen here. And plastered to the posterior abdominal wall are the kidneys in section. They look oval in shape. This is the left kidney, and here's the right kidney. So to make things look better, I will try to draw the vertebra. This is supposed to be T12 vertebra, another transverse process on the right side. And here is the vertebral canal. So in the periphery here, it's the body wall where there are muscles and ribs here, because ribs are also related to the liver, abdominal viscera, liver on the right side, and on the left side the ribs are related to the spleen. 9, 10 and 11th rib are also related to the spleen, and here there are muscles of the erector spinae muscle and some muscles of the posterior abdominal wall, which I am not going to draw. Let me put the two major vessels here in the posterior abdominal wall, that is the aorta and the inferior vena cava. So this is the aorta. The aorta is toward the left side. So this is the aorta. The aorta is toward the left side, and here is the inferior vena cava. It has thinner wall, being a vein, and a little bit flattened. It's on the right side, the inferior vena cava. Now I will draw the parietal peritoneum, starting, it is in blue again, starting at a point on the anterior abdominal wall in front of the liver. This is the parietal peritoneum of the anterior abdominal wall, going back to the posterior abdominal wall until it reaches the site of the kidney, and at this point it is going to cover the kidney, so it will become a visceral peritoneum. Drawing it in pink, covers the kidney and is reflected from the kidney as a fold. This is one layer of the fold extending from the kidney into the spleen, and this is called the lieno-renal ligament. Lien means spleen, and renal, lieno-renal ligament. Peritoneum encloses the spleen completely encloses the spleen. So the spleen is an intraperitoneal structure, and return back to the hilum of the spleen, where the lieno-renal ligament originally was attached. This is the region of the hilum of the spleen where vessels pass in and out of the spleen. And then it's going to be reflected into the greater curvature of the stomach in a double fold of peritoneum. This is one layer of the fold to the greater curvature of the stomach, and this is called the gastrosplenic ligament. Gastrosplenic ligament. We will notice that all these folds and ligaments, most of them contain blood vessels, and so from the greater curvature of the stomach, the visceral peritoneum covers the anterior surface of the stomach and reaches the lesser curvature of the stomach. At the lesser curvature of the stomach, it is going to be reflected towards the liver, and this fold of peritoneum is called the lesser omentum. It has a free border, so I'm not going to attach it here in section directly to the liver because representing it's a free border. So this is the free border here. It's a thick border returning back into the lesser curvature of the stomach, and from the lesser curvature of the stomach it covers the posterior surface of the stomach until it reaches the greater curvature and reflected back to the spleen. So the visceral peritoneum here on the posterior surface of the stomach will reach the greater curvature of the stomach and will be reflected from here to the hilum of the spleen again, creating the second layer of the gastrosplenic ligament. Then from the hilum of the spleen it will be reflected back onto the kidney, creating the second layer of the lieno-renal ligament, the double fold of peritoneum, and then around the kidney. The kidney has no mesentery. It is a retroperitoneal structure. In fact, it's a primary retroperitoneal structure. And now the peritoneum will become parietal peritoneum. It covers the posterior abdominal wall. At this position, there is psoas major muscle, and then passes in front of the abdominal aorta and the inferior vena cava, and then reaches the right kidney. So when it reaches the right kidney, it becomes a visceral peritoneum. I'll draw it in pink, covering the anterior surface of the kidney. The kidney has no mesentery, and reaching back to the posterior abdominal wall, becoming parietal peritoneum. So I'll draw it again in blue. And returning to the same point where we have just started. From this point, it's going to be reflected as a double fold of peritoneum. Now I'm going to draw one of the leaves of this double fold, and this is the falciform ligament, one of the leaves of the falciform ligament, extending from the diaphragm, anterior abdominal wall to the liver, and the peritoneum encloses the liver, completely surrounds the liver here. Of course, there is a bare area which is shown in longitudinal section, but not in this section. This is the visceral peritoneum covering the liver, encloses the liver, and then this is the second fold, or the second leaf of the fold of the falciform ligament, returning back. So you can see again that the peritoneum is visceral and parietal. It is a continuous sheet of peritoneum, changing names and having folds, different folds, as we have just seen: the falciform ligament, the lesser omentum, the gastrosplenic ligament, the lieno-renal ligament. And it's a continuous cavity, which is actually, I said it's a potential space, but here it has been exaggerated. Here, this is the greater sac of peritoneum, and the lesser sac is located behind the stomach and the lesser omentum. So this is the lesser omentum, and this is the lesser sac. it has an opening here, which is between the free border of the lesser omentum and the inferior vena cava, which is located posteriorly. And this opening is the same as this one. It is the epiploic foramen. And this is again the direction of the arrow, which passes into the foramen from the greater sac to the lesser sac. In the free border of the lesser omentum, there are three structures. A posterior structure, which is big, and this is the portal vein. And then there are two anterior structures. One of them, I'm going to draw it in green, and that is located on the right side. And this is the bile duct. And the other one, I'm going to draw it in red. It's an artery. It is the hepatic artery, located on the left side. The bile duct is located on the right side. Both of them are located anterior to the portal vein. And so the epiploic foramen here, when you pass your finger into the epiploic foramen in order to enter into the lesser sac, your finger will be located between the inferior vena cava posteriorly and the portal vein anteriorly. If you go superiorly, you are going to touch the liver, and if you go inferiorly, you will touch the first part of the duodenum.
So in the previous slide we have seen the tracings, vertical as well as horizontal tracings of the peritoneum, and this diagram tells clearly about the vertical tracings, and with the help of this diagram we can draw the vertical tracing easily. For horizontal tracing, the abdominal cavity is divided into two compartments, and transverse mesocolon and colon, the transverse colon is taken as the dividing line for these two compartments. The compartment above the colon and the transverse mesocolon is called as supracolic compartment, while the compartment below is infracolic compartment. For supracolic compartment, if we trace the peritoneum horizontally, we will be able to clearly see the lesser sac and the greater sac, and lesser sac which lies behind the stomach, as we have already seen in the video while drawing the horizontal tracing. Before we start with the tracings of the infracolic region, we should discuss about certain structures which are seen on the peritoneum immediately after removal of the anterior abdominal wall. These structures are seen as median umbilical ligament, then a pair of medial umbilical ligaments, and a pair of lateral umbilical ligaments. These structures, they raise a fold of peritoneum, like you can see here, inside the peritoneal cavity, and these are called as umbilical folds. So the median umbilical ligament, it is a fibrous band and it represents the remnant of urachus. Urachus is an embryonic structure which is a communication between the apex of the urinary bladder with the umbilicus. So in life, once the child is born, this urachus it becomes solid cord-like fibrous structure and is known as median umbilical ligament. Then on either side of the median umbilical ligament there is another fold or another structure which is also a remnant, and it is termed as medial umbilical ligament. This medial umbilical ligament represents the remnant of umbilical arteries, and because it is umbilical artery is no more required afterwards, so it degenerates and remains as a fibrous band once again, which connects the umbilicus to the up to the level of anterior division of internal iliac arteries. Initial part of this umbilical artery remains as artery to the urinary bladder or superior vesical artery. But here we are talking about the medial umbilical ligament, which is raised by the remnant of umbilical arteries on either side of the median umbilical ligament. Then the lateral umbilical ligaments, these are formed by the underlying inferior epigastric arteries, which are branches of external iliac arteries. So these folds will be seen in the anterior abdominal wall, and these folds will be these ligaments are seen in the anterior abdominal wall, which raise a fold towards the peritoneal cavity, and hence they are also known as, these folds of the peritoneum are called as umbilical folds. So when we trace the abdominal cavity, so peritoneum in the abdominal cavity, especially infracolic part, so what you will find, we will find a peritoneum right from the beginning. We will find that there is a fold raised because the median umbilical ligament, then medial umbilical ligament, then after that lateral umbilical ligament will raise the fold, and then the peritoneum will run along the wall of the abdomen, and then it will cover on the anterior and the lateral side of the colon on either side, that is ascending as well as descending colon. Then it will run again on the posterior abdominal wall, and from there it will raise the fold of peritoneum called mesentery, and then it will cover the small intestine, and then second layer of the mesentery will also be found, and then again this peritoneum will go back onto the posterior abdominal wall on the right side, covering the inferior vena cava, then again covering the ascending colon and coming back to the anterior abdominal wall where the folds were being raised by the umbilical ligaments. Then in the anterior aspect, anterior to the intestine, there is presence of greater omentum. And greater omentum, as we have seen in the tracings, that it is a 4-layered structure. There are 2 anterior layers and 2 posterior layers, and in between the 2 there is a lesser sac. This lesser sac is seen only in young children in case of greater omentum, because later on these peritoneal folds, the walls of the peritoneum, they fuse, and the lesser sac does not extend up to the greater omentum in adults. So here you will be able to see the lesser sac, of course, in case of small children, with greater omentum, all 4 walls in the anterior aspect. Posterior to that, we will see the intestine and the mesentery covering the intestine. So when the peritoneum is going on the posterior abdominal wall and then covering the colon on either side, whether ascending or descending, because it is covering on the lateral side also, so it forms depressions on either side of the colon, say the medial as well as the lateral side of the colon. Similarly here also, these are called as paracolic gutters. That is, around the colon there will be depressions which are formed by the fold of the peritoneum here. So these are called as paracolic gutters. So this is how the peritoneum is running in the infracolic part if you start tracing it horizontally. Then clinical and applied aspect of the peritoneum. First of all, if there is any inflammation of the peritoneum which can occur because of the inflammation of the underlying structures or underlying viscera, like say in case of appendix, it may lead to appendicitis, and which may involve the covering peritoneum also. And this inflammatory response is the inflammation which occurs here is called as peritonitis. This inflammation of the peritoneum can involve the whole of the peritoneum all over, right? This is called as generalized peritonitis, which generally occurs because of the perforations of the intestine, or say some in certain surgical procedures, following some surgical procedures where we open the peritoneum and the abdominal cavity. Then it can be localized in case of appendicitis. Then accumulation of fluid. Normally I told you there is a very minimal amount of fluid, peritoneal fluid is there, required only for the lubrication. But in certain conditions there can be increase in the peritoneal fluid, and the condition is called as ascites. This peritoneal fluid, collection of more fluid inside the peritoneum can be diagnosed with the help of ultrasonography or CT scan. The fluid which collects within the peritoneal cavity in case of ascites, it has to be removed with the help of by introducing a needle inside and then draining through the drain into the collection bag, and this process is called as paracentesis or the peritoneal tap. So the collection of blood in the peritoneal cavity is called as hemoperitoneum, which can occur due to the rupture of blood vessels or rupture of uterine tubes in case of ectopic pregnancy, or rupture of viscera which have a lot of blood supply like liver and spleen, and this is generally seen in case of roadside accidents. Then if there is collection of air within the peritoneal cavity, that is known as pneumoperitoneum, and this is generally seen following intestine perforation, and it can be diagnosed easily with the help of a plain X-ray chest, where we can see presence of air under the dome of the diaphragm. This dark color area is showing the air, and this white color area is the dome of the diaphragm. This is a normal X-ray where you cannot see any dark colored area under the dome of the diaphragm, because it is formed by the, say, liver, which is a solid viscera, and it is giving a radio opaque shadow. But presence of air under the dome of the diaphragm will give a radio lucent shadow, that dark shadow, which shows that there is air under the diaphragm, and this can help in diagnosing the pneumonia. Any damage following infection, surgery or injury in the abdominal cavity will lead to immediate inflammation followed by repair. Repair is generally led by fibrous scar tissue formation, and this scar tissue formation leads to abnormal attachments of the peritoneum with the organ or within the two layers of the peritoneum. These adhesions or abnormal attachments, they lead to various problems, like they will be compressing upon the viscera over which it is passing, and that compression can lead to pain, visceral pain, and patient may complain of abdominal pain, chronic abdominal pain. Or in some cases, because of these bands or adhesions, this in part of the intestine close to it may get twisted because of these abnormal bands or adhesions, and that may lead to obstruction of the intestine, and this is called as volvulus. So here this picture is depicting this is the normal large intestine, and this is the twisting which has occurred in this area, and this twisting has led to the loop of intestine which has become swollen, and because of the twisting, and this twisting is labeled as volvulus. Then the peritoneum is also useful in certain treatments, especially in case of renal failure. It is used as a method for the removal of the waste material, because once the kidneys have failed, they are not able to remove the waste from the body. So in that case, the peritoneum is or the cavity of the peritoneum is used for the removal of the waste by using some solution, generally saline, different type of saline solutions, which will be injected or inserted inside the peritoneal cavity, and then after some time it will be removed from the peritoneal cavity, and this is known as peritoneal dialysis. This is all about the peritoneum and in general, and in the later lectures we will talk about the various ligaments and the greater and the lesser sac. Thank you.